feel like I'm going to get so much teasing from colleagues on this. Hi, I'm Dr. Georgia Mills. We've gathered some common questions from GPs about lymphocytosis. This includes everything from understanding the difference between absolute and relative lymphocytosis to causes, diagnostic approaches, and management of conditions like monoclonal B lymphocytosis and chronic lymphocytic leukemia. There's a lot to cover, so let's dive in. All right, so here's a good question. Are there any bacterial infections that are likely to cause a marked absolute lymphocytosis in an adult, mimicking a haematological malignancy? So as you probably know, patients with bacterial infections more commonly have neutrophilias or left-shifted granulopoiesis, so you might see things like myelocytes or metamyelocytes written on the blood film, but sometimes in more atypical circumstances, you can get a lymphocytosis with certain bacterial infections, and one of those would be Bordetella pertussis or whooping cough. And I have seen patients who have presented with an isolated lymphocytosis out of proportion to the neutrophil count, where there has been a question of could this be a hematological problem or a lymphoproliferative disorder? But in that case, flow cytometry has ruled that out, and microbiological tests have confirmed Bordetella pertussis. There's some other more uncommon bacterial infections that have been known to cause a lymphocytosis, including Bartonella or cat scratch disease, and even syphilis can cause a lymphocytosis that might mimic malignancy. But typically, as you know, neutrophilia equals bacterial infection. Here's a good question. So is a high lymphocyte count absolute or relative? Of course, it can be both, but generally speaking, looking at a high lymphocyte count, it has to be greater than the reference range of 4 × 10 to the 9 per litre to constitute a lymphocytosis. I suppose there might be some conditions where you get a low neutrophil count and I suppose a relative increase in lymphocytes in relation to the neutrophils or other white cells. But generally, when I'm referring to a high lymphocyte count, I want to see that it's higher than the reference range of 4 × 10 to the 9 per litre. What are some causes of lymphocytosis? So I'd categorise these into reactive or haematological causes, and in the reactive category I'd go viral infections, bacterial infections, atypical infections, things like burns, autoimmune disease, seizures, cardiac arrest, anaphylaxis can all cause a reactive lymphocytosis. And then haematological causes would include leukemias, lymphomas, and lymphoproliferative disorders. This is an interesting one. What is your approach to the diagnosis and management of monoclonal B lymphocytosis? So, monoclonal B lymphocytosis, or MBL, is quite a common phenomenon in my haematology practice, both in the laboratory and clinically. So patients will often present to their GPs or other practitioners with an isolated lymphocytosis, similar to our case study. To diagnose monoclonal B lymphocytosis, or MBL, you do a blood film confirming lymphocytosis and flow cytometry confirming a population of abnormal B cells. And then you also go on to do a clinical assessment of the patient, looking for any symptoms of a lymphoproliferative disorder. Do they have low healthy blood counts, such as anemia or thrombocytopenia? Do they have constitutional symptoms such as fevers, night sweats, weight loss, symptomatic lymphadenopathy or hepatosplenomegaly? And then you go on to monitor them for any new symptoms and any progression of their lymphocytosis every 6 to 12 months in routine follow-up. Okay, interesting one. So a patient has persistent lymphocytosis in low ranges and flow cytometry confirms monoclonal B lymphocytosis, or MBL, of CLL phenotype. There is no lymphadenopathy or splenomegaly, and how should this be managed? So this is a very common scenario in my clinical and laboratory practice. Generally speaking, patients with asymptomatic MBL, especially if they have a low absolute number of abnormal B cells, so less than 0.5 × 10 to the 9 per litre, and no constitutional symptoms, no lymphadenopathy or splenomegaly, can be monitored through surveillance with clinical assessment and laboratory testing every 6 to 12 months according to guidelines. And usually we'd be looking for a rise in the absolute lymphocyte count, a rising LDH, which can indicate increased disease tempo and cell turnover, abnormal biochemistry, including elevated calcium, abnormal blood counts, including anemia or thrombocytopenia, and most importantly, any constitutional symptoms, so fevers, night sweats, weight loss, or symptomatic lymphadenopathy or splenomegaly. In the absence of those symptoms, you can continue to monitor them every 6 to 12 months, and probably even 12 months with low-risk MBL, and this can be done in the primary care setting in consultation with a clinical haematologist. Here's another case study of a 65-year-old patient known to have CLL monitored in the community who presents with a 2-week history of drenching night sweats and a 5-kilogram involuntary weight loss. The latest full blood count shows a doubling of the lymphocyte count to 35 × 10 to the 9 per litre over 4 months. What should be the most appropriate management? So in this case, assuming that this is my patient and I'm in the primary care setting, I'd be quite concerned that the patient might be meeting the International Working Group of CLL or IWCLL criteria for treatment, and those would generally include a lymphocyte doubling time of less than 6 months, indicating an increase in disease tempo, symptomatic cytopenias including anemia or thrombocytopenia, neutropenia, symptomatic splenomegaly or rapidly growing lymph nodes, and if they meet any of those IWCLL criteria, they need treatment. And that usually involves referral to their clinical haematologist, restaging of the CLL and checking for any Richter's transformation on imaging and further blood test investigations, and then generally speaking treatment with targeted agents such as Bruton tyrosine kinase inhibitors, BCL2 inhibitors, and potentially a CD20 monoclonal antibody in combination. A patient has persistent low lymphocytosis, and on the pathology report, the blood film notes small, mature-appearing lymphocytes and smudge cells. The patient is asymptomatic. What is the most appropriate classification of this condition, and what is a smudge cell, and what is their significance? What is a smudge cell? So a smudge cell is, in common terms, a cell that's destroyed in the process of making a blood film, and it can occur in patients with underlying lymphoproliferative disorders or CLL. So unlike normal white blood cells that when smeared on a blood film don't break, these cells are a little bit more friable and they break during the preparation of the blood film, and we see lots of sort of smeared or smushed blood cells. And when I see this, I think this could be CLL. We should do flow cytometry to confirm or exclude a lymphoproliferative disorder. This is a good one. So what is something that excites you about the future of healthcare? There's so much that excites me about the future of haematology. I love going to conferences and learning about the latest targeted therapies available for treating haematological malignancies and also non-malignant haematology. I think it's continuously evolving. We're trying to treat patients with the least amount of toxicity, both short and long term. And some of these agents work amazingly well. I love learning about bispecific T-cell engagers, CAR T therapy, clinical trials, oral options, and I love the fact that the future of haematology is chemotherapy-free. So that wraps up our questions for today. I hope this discussion has helped clarify the causes, evaluation and management of lymphocytosis and given you some practical points to apply in your practice. Thanks for watching.